All right, so formal welcome to everybody. This is a presentation that is done in conjunction with the Florida Stroke Registry, which I'll get into in a little bit. And this is the inaugural meeting for the Space Coast Stroke Coalition. I'll explain to you what the coalition are, what they mean, and why they're important, and then how it's going to impact you, whether you're on the EMS side or whether you're on the hospital side. And at 2:30, we have the Florida Stroke Registry folks who run the registry. I've worked with them since 2012 on this, and they'll come in and really be able to talk about the registry more, kind of globally from the state perspective, what we're doing nationally, the papers that we're writing, and how it's impacted stroke care across the state of Florida. So the story for me is personal. And when I give this talk across the country, I start off by talking about a gentleman who is 67-year-old, no prior medical, had an ischemic stroke at 5 a.m., found at 7 a.m. on the floor. Of course, they did not know the initial time of the stroke, so he was transported back then to the hospital that I work at, and he was treated as a stroke of unknown downtime, and therefore, back in the day, this is many years ago, they did nothing for him, and ended up in a vegetative state for quite some time. Couldn't speak, was in a wheelchair, etc. And unfortunately, this is my grandfather, and boy, did this upset me. Then I became a medical director in 2010, and I learned there's a whole nother big problem, which is that we were transporting patients to a primary stroke center that did not have a comprehensive, let's say, mothership. And we had a lady who had, let's say, some blood on her tongue, and therefore it was deemed to be a GI bleed, and therefore they did not transfer that patient to the comprehensive center. And we started finding out about these things only, let me mute this person, hold on. Okay. We only started finding out about these things when we started doing EQI. We would call up, hey, how's Mrs. Jones doing? Was she ever transferred out for her LVO? No, why not? Well, and then we walk into the hospital to find out. And what we discovered there this is now back in 2012 timeframe, we started to recognize that there was a big problem. So obviously I was bringing about South Florida, and then I bring about everywhere else. But if you're a PSC, which is the green, and you have a CSC that's far away, the question is what do you do, right? If you're EMS, which is the blue star here, and you have a number of hospitals to transport to, where do you go? And so finally, after we did what we did here many years ago, guidelines started to come out in 2013. And initially they said transportation times to reach another facility should be limited to no more than 15 to 20 minutes. Okay, so remember that time frame. So if you had a CSC within 15 to 20 minutes, the recommendation, even back then, was to go to a CSC. That wasn't in vogue back then. But then I think these are the most up-to-date recommendations that you could see here, that if an LVO is suspected and there's a CSC within 30 minutes, max transport time, then this is from the American Stroke Association, not coming from South Florida. This is coming from the national folks. Either go to a TSC or to a CSC. So things have changed even at the national level now, based on the capabilities you have in your neck of the woods. This has been out for many years now in the New York Times, in the Wall Street Journal, and they came out in the Wall Street Journal in 2018 saying, hey, depending on where you live, may depend on your outcome from stroke, because these hospitals may or may not be doing the procedure and needed, just like they did not do the procedure on my grandfather back then, in the early days. So everybody talks about door to groin or door to puncture times. This is Nils Mueller-Kronatz. He's someone here in South Florida that we've been doing research with from the very beginning. And basically, it's very easy to see that your functional independence at 90 days, all matters on how long it took you to get from EMS on scene to groin puncture. Really, it's from the 911 call is really the time that we should be measuring. If you do go to a PSD and then you get transferred to a CSD, um, there are many delays. This is one paper. We published another paper. And it turns out, by the way, that not only are there delays, door in, door out delays, but there's also delays in people calling 911. Probably the biggest delay, about 300 minutes, is what we found when we published our paper. So, again, lots of data, early data to show that getting the people to the right place the first time is matters the most. So we all knew that change was needed, right? Because we were taking people to some hospital. We weren't getting any information back. We were only getting information back one patient at a time, never on the aggregate. And it was very hard for the hospital to understand where they were. It was very hard for the EMS system to understand what was going on out there with stroke care. So we ended up going through a very long, it's been almost 15 years now, um, probably, probably 14 years now, where we've been working on this particular problem. Many of you know the golden hour for IV-TPA, which is basically this in-series process. The patient gets your ED, the doc evaluates, call the stroke team, you get the CT scanner. And this is kind of old news now, right? The 60 minutes is the golden hour for TPA. This has significantly changed now to 30 minutes. And we'll talk more about that in a minute. But this door to needle time of 60 minutes has moved. The goalposts have moved pretty significantly because 60 minutes is way too long. And by the way, all of these data metrics, imagine that I could give you a spreadsheet or some dashboards that provided you with your hospital's metrics um, every single quarter. And that's exactly what we're going to be doing here once we get this coalition fired up. Again, I know this is a little bit of old data. I think this is the last data slide for the old stuff, but this is impactful for me because we worked for 2 or 3 or 4 years to get people to understand that thrombectomy was important. And finally, in 2015, that's finally when the endovascular trials all came out, pretty much all in a row, saying that yes, thrombectomy is important in acute stroke, and therefore, this is the moment where things really started to change, and you felt like the gravitational shift. And here we are now, almost 10 years later, and Florida is the first state that has really gone this deep with respect to a registry that is this impactful, that collaborates with EMS and the hospital both at the same time. So what we're trying to do here with the Florida Stroke Registry is now bring in the Space Coast into the registry, meaning that all of you will now be getting something that you have never gotten before with respect to these regional dashboards. Some of you may be getting them, I don't know. But now that we're going to get EMS and the hospitals together, the goal is to start today. This coalition, kind of had everybody under the tent, right? Primaries, comprehensive, thrombectomy capable, stroke coordinators, administrators, neurointerventionalists, of course, the EMS physicians. And we'll have quarterly meetings where everybody participates. There's going to be a presentation every single time. And that presentation will be decided based on, who ends up wanting to lead the coalition and who wants to be kind of like, heading up the agenda and so forth. And we can talk about that in, after this meeting is over. And then what's going to end up happening is that on these meetings, we'll talk about best practices. We will talk about the dashboards themselves. And then a little later on today, we'll have the Florida Stroke Registry folks on board here we'll talk about the coalition itself, and then I can answer questions that you have that come up along the way. So I'll let the Florida Stroke Registry folks introduce themselves when they come in. It's a pretty large group of people, and I'll show you who kind of started this whole thing. But the Florida Registry is now it gets appropriations from the state of Florida to the tune of, I think, $2 million a year, and because of that, they have to basically demonstrate that they're actually providing value. So the state is actually looking at this registry, they're looking at the data coming out of it, and they're expecting publications based on what we're seeing. And our publication is about to get published, hopefully any day now. It's a pretty big publication. The guy at the top left of the screen is considered a legend amongst anyone who knows stroke in this country and maybe around the world. And unfortunately, he passed away last year. Dr. Ralph Sacco worked at the University of Miami. He was the head of the American Stroke Association. This guy's a legend. And he basically, just to kind of get you, how did we get here today? He had an NIH-funded grant in 2012 called the Florida Puerto Rico Registry. They were looking at disparities between stroke, between men and women, different races, etc. And in 2017, that the grant was going to expire. That's when somehow or another we all got connected, and myself and a few other people said, "Hey, this is a great piece of software you have. Instead of shutting it down, can you transform it so that you could take EMS data and collaborate into the hospital so we can get a registry that actually is beneficial for the whole state?" And I got to give Dr. Sacco credit. He said, "Let's give it a try." And that was how the Florida Stroke Registry was born. We made a number of strides, so much so that in 2021, the federal government awarded the CDC Paul Coverdell Acute Stroke Program to the state of Florida, which means that we get more money, more support, and now our data goes into a big national database. And that was a pretty big deal. And then that award just got renewed in 2024 for another, looks like 5 years. In that time, the registry now has almost every single stroke center in the state in the registry. That was an incredible feat in and of itself, meaning that when you're going to see data in the registry, it's not just a couple of hospitals. You're going to be compared to the other hospitals in the county, other hospitals in the region, and then you're going to be compared to other counties across the entire state. So you're going to see for the first time, how do you add up as a hospital system? And of course, EMS is involved in that, but how do we add up for community stroke care compared to everybody else in the state of Florida with specifically 11 different metrics? And I see that we have Jillian from the Stroke Registry is joining right now. Oh, here comes Carolina. Perfect. All right, hi Carolina.
But we're happy to be here, and thank you for letting us join late.
This is your inaugural meeting. I'm super excited for that.
Yes. I kind of gave some background. Would it be okay if you took over and just gave everyone a little bit of background? I gave them some overall background, but if you wanted to dive deep into the stroke coalition model, that'd be good.
I can do that, Jillian, and then if you want to, as soon as we get to the dashboards, I can hand it over to you. Does that work for you as well, Peter?
Perfect.
Perfect for me.
Thank you. So I'm happy to give you all this quick overview of the model, and thank you again, Peter. I think the main point of this is that the Florida Stroke Registry didn't invent stroke coalitions. We're not trying to say that, but thanks to the collaboration with Peter and with folks out of Broward, Palm Beach, many years ago, and of course, Dr. Sacco, who was involved way back when, there were already coalitions that were existing, but they came to the table to the Florida Stroke Registry and said, we would like to get together in a certain kind of way and really focus on quality improvement. And the quality improvement that we want to do needs to be directed by tracking and measuring tools. And so as a Florida Stroke Registry, we capture data. predominantly from hospitals. And so the idea was to be able to collect this data locally, particularly within Broward, Palm Beach, and those specific areas that have stroke coalitions, and begin to offer these report cards or dashboards to these coalitions. The 7 that you see below, the reason why they all look kind of alike is because we, in the Florida Stroke Registry, we have a website where we offer each of the coalitions that have been formally formed a place on our website where they can show meetings like this one, talk about the next meetings that they're going to have, talk about anything that they'd like to as a coalition and or share with other coalitions. But the model in particular has to do with, again, volunteerism and service specifically to your local community, focusing somewhat primarily on quality of care. And of course, each coalition has its own needs and own focuses that go outside of this. But if that's a specific focus, then of course you can use our FSR regional dashboards. Those are made up of 11 measures, and soon what Dr. Gordon-Peru is going to talk about are the 2 extra measures that we're soon to disseminate to you all, the door in, door out. Of course, Dr. Antevi was part of that task force and a few others from around the state. But the regional dashboards, again, she'll get into it. There are 11 measures, now soon to be 13, that have been defined by our advisory committee. They're specifically reperfusion measures and measures that are important to both PSC and comprehensive stroke centers, and very important to our EMS partners as well. Another aspect of the Stroke Coalition model is that we work towards data transparency. So we like to have hospitals and EMS at the table, and through some of the FSR's new initiatives, we also like to include community health workers and other stakeholders that are important in directing some of these initiatives and interventions. But data transparency is a huge piece, and thanks to Dr. Antevi pushing this, FSR is trying to make this happen. Let me move on to the next slide because I might be talking about things exactly from the next slide. So you're seeing these little images here. These are the 7 stroke coalitions that we currently recognize as through FSR. Again, lots of stroke coalitions exist, and we're trying to collect where else they may exist beyond these areas. But these are the ones that are abiding by and following that model, and to some degree adding characteristic to that model that might be specific to their area. So nothing is set in stone. It's just that this general model works so far for the past, I think we've been around, these coalitions have been around at least for 7 years. And some of the original coalitions beyond FSR, like for example, the West Central Florida Stroke Council has been around for almost since 2001, I think. In Broward, that coalition has been around easily more than 10 years, maybe 15 years, I think. And then, of course, Foam D Stroke Coalition, which is very EMS specific, has been around for multiple years as well. But so again, the logos show you the coalitions that are existing and that are currently using the regional dashboards specific to their areas. The little yellow circles and the circle, the outlined area are areas that are trying to become stroke coalitions. And what's specific about the one in the Tallahassee area, it's very interesting because they do not have necessarily hospitals other than their main hospital. So this may be a new model, one that involves some of the freestanding sites. Your area is obviously to the right of the yellow stuff, which would be the Central Florida Stroke Coalition. Again, also kind of led or maybe nudged by Dr. Antevi. So we're looking forward to seeing yellow in the counties that you guys are interested in. You can go to the next one. Thank you. So now I'll hand it over to Dr. Gordon-Peru, and wherever Antevi, Dr. Antevi, would like to step in as well, because you are a huge part in these becoming a reality.
Yes.
Thank you so much.
And so thank you, Dr. Gutierrez. As Dr. Gutierrez just said, this has been really led by grassroots efforts. While stroke policies and standards are global, what happens on the ground is local. And so it's really important that EMS, the emergency room physicians, and FSR own this process for what happens to us locally. And so this is focused on quality improvement, improving triage of patients for the delivery of stroke, and then making sure that hospitals who are doing well get credit for the work that they're doing, but in that process of transparency, feedback to EMS. Additionally, by talking about these through stroke coalitions, you can now start discussing best practices and applying those. If something's working really well in one hospital, maybe it would work well in your hospital as well. And you can, in a real sense, see how you're measuring up and benchmarked, not just against what your system of care is doing, but what another system of care is doing, what the state, county, and really the national benchmarks are. So if you go to the next slide, this is our current dashboard. You'll see that there are 11 reperfusion measures. This on your right is a snapshot of what it looks like. I'll dive deeper into each bar to explain it to you. And you can see there are 6 thrombolytic measures and 5 endovascular measures. And then new to us will be 2 door in, door out measures that we'll get on this first quarter of 2024. And these really surround timely, quick treatment for stroke. So overall thrombolytic rates, door to needle times, and making sure patients have good outcomes, modified ranking score at discharge with good questions for safety, looking at the symptomatic intracerebral hemorrhage rate. And then for EVT, it's door to puncture, and again, outcomes and symptomatic rates. If you go to the next slide, you'll see sort of a zoomed in version of what this looks like, and you'll see our performance over time. So in the first bar, that overall quality of care is actually a Florida Stroke Registry defined metric where we take all the quality measures and put them together. You'll see in 2010, when Dr. Sakos defined this, it was low. Only about 8% of all stroke patients were getting high quality defect-free care. And now in 2023, that number is up to 88%. Similarly, you'll see there's improvements in endovascular therapy, 2% in 2010 and 14% in 2023, which is among the highest in the country. You see thrombolysis treatment rates there. Treating those patients who arrive kind of at the end of the thrombolysis window, arriving by 3.5, getting treatment by 4.5 has also improved statistically significantly. And those patients, you don't just want to wait until they're about to be outside the treatment window, right? You want them to come in and everybody get treatment as quickly as possible. So you see those patients that get treatment within 45 minutes of hospital arrival has gone from 6% to 84%. And it's truly been just remarkable seeing what these dashboards have done for improving stroke care here in Florida. And I dare say that Florida is probably the best in the country. This is more details about the dashboard. So you will see at the top, you'll have your individual hospitals, and at the bottom in gray, you'll see the different sort of standardized regions. So Florida, overall, IV TPA treatment rate is 12%, with a median door-to-needle time of 33 minutes. That is incredible. Then you see the breakdown for each individual county. Some counties are faster than others. Broward is probably the fastest at 27 minutes door to needle, all the way up to Emerald Coast at 40 minutes, but that's still incredible. Remember, the benchmark is 60 minutes, 45 minutes by Get With The Guidelines, so still incredible times. And the percentage treatment rates varying from 10 to 16%. So yours will be on one of these bars when you start getting your dashboard. Next slide.
Yeah, I just changed it. Yeah, you're on EVT now, yep.
Yeah, so EVT, it looks almost the same, eh? So EVT,
Yeah.
so instead of thrombolysis treatment rates, it's EVT treatment rates. And that's remarkable that the percentages are in the teens. In many parts of the US, the EVT treatment rates are 2%, 5%, 10%. This is actually pretty dramatic that we're between 13 and 17%. The door to puncture times still have opportunities in some counties. Remember, door to groin puncture times should be within 90 minutes. So you can see overall in Florida, we're well within that measure, 78 minutes. But there's some centers that have some opportunities that are just above that 90 minute. Next slide. And so new to the regional dashboard is going to be the door in, door out times. And what we're showing you here is the overall medians for the different counties. We're going to be showing you on the dashboard door to needle times for ischemic stroke and door to needle times for hemorrhagic stroke. A lot of the coalitions told us they wanted to see that broken out, because what drives your process in the hemorrhagic stroke is very different from what drives your process in the ischemic stroke. Sometimes the hemorrhagic stroke patients need an EVT, sometimes they need intubation, and it can take a little bit longer. But this is your median time overall, both ischemic and hemorrhagic combined. And you can see that the benchmark, the Get With The Guidelines benchmark should be 120 minutes. And we're all above 120 minutes. The overall median time in Florida is 160 minutes. And you see the fastest time is Miami-Dade and Palm Beach. And then others still with opportunities. Some of this has to do with small numbers and how it's documented, but by putting it on a dashboard and having us have the conversation about this, we can start driving the numbers and improving. I'll tell you, in the last Miami-Dade coalition call that I went to, they were talking about their door in, door out times and improving it, and you can see that driving the measures here. So start seeing that on your dashboard so that we can improve that. So how do we get these numbers? Basically, once the hospitals abstract their data into Get With The Guidelines, the FSR core team will download that data and clean it, make sure it's good quality, and then develop those dashboards and graphs. These graphs are then put into the regional dashboards, which we and you guys are able to access by the FSR Secure website. You would log in using your credentials and then go to Stroke Coalitions. And there you'll be able to see the dashboards as it relates to both your hospital as well as the regional dashboards. And then the EMS directors can help you guys request unblinding. So if you go to the next slide, it talks about that transparency piece. So the EMS directors in their special access will be able to see who are the stroke medical directors for that region, who's the stroke center, who's the stroke coordinator, and then each hospital tells you what their letter is. Each of these bars, the orange and blue and aqua, represents a different hospital. So for example, I'm in Jackson South. So for that dashboard, my letter is F. So you would then be able to see as an EMS director and as a region, hospital F is doing this, hospital A, B, and C are doing that, and how it compares by volume and by location. Okay.
And I think that's important, and we didn't really go over that just yet, but the colors of the bar of the graph is related to the volume of patient that you're seeing, right? So think of it as small, medium, and large, or low, medium, high volume. So yeah, if you wanted to just describe that a little bit too, that'd be great.
Sure. So the volumes are based on actually the number of ischemic strokes that are taken care of by that hospital per year. The larger hospitals may be comprehensive, but they're not necessarily, right? Depending on your location. So the first bars, the set of oranges, will allow you to see if I'm a small volume hospital, how well am I doing with regards to other hospitals of my size compared to the state and the region, and so on and so forth. Because it's not just the level of acuity that you can take care of, but also your volume. Does that make sense? So if we go to Then, of course. So if you go to the next slide, this is how to contact us. There's actually, I'll go back one. There's actually a manual that Dr. Gutierrez and team has made that actually walks you step by step through how to get access to this Stroke Coalition webpage, how to get set up and how to utilize it. I'm sure she's happy to share it with us all. It sort of walks us through step by step through getting access to these dashboards. And typically what happens in the coalition calls is that the dashboards are shown and we discuss how to improve the quality of care in your region.
And I'm happy to share this with everybody after the fact, after the meeting today, but that's great to know that we can disseminate this document.
Yes, yes. Okay, Dr. Gutierrez, you want to come back? We can talk about the Stroke Coalition impact.
I can run through this real fast. It's really just to again, congratulate you all for coming together and to let you know that you have a lot of power here. We're developing, and I know not everything is about power, but you know, if you need change in your local community for things that are important for the quality of care, just being able to get together and strategize and organize is super important. And obviously through the FSR, you have a vehicle to the state to tell the state there's a gap here, they need a little bit of help here, or they're doing amazingly here. You know, so I think this is the value that we've seen with the stroke coalitions. There's been requests through some of the clinicians and of course the community in general for improvements in this whole quality of care piece with regard to certifications on hospitals. And so back in 2017 is when some of the hospitals got together and said, well, actually, yeah, it was 2017, and they actually developed policy for requiring that all hospitals that are going to see stroke patients, that they become nationally certified. I have my dates wrong. It's actually 2021. And so in 2021, a group of the advisory committee got together, went to legislation, and put together some data from the FSR. And this kind of legislation became a reality thanks to these stroke coalitions and thanks to their participation in the FSR. That's the very last piece there, the systems of care piece, and actually the 2019. I also want to remind, yeah, that's okay. We can move on to the next one. I also want to let you all know of a new initiative, which is our Coalition of Coalitions. We had the first meeting at our annual FSR meeting in August. The idea is to bring together all of the coalitions. You saw 7 of them. Now you're going to be 8. Come together at an annual meeting in person. If you want to come in by virtual, we also had a virtual option, but to basically talk about what's going on across the state in these little clumps of groups. What's a goal that those clumps of groups are having, if they're similar to others. What we found, you know, we've been having these annual meetings for the past 12 years. Next year is going to be 13. And what we found is that many of our stakeholders are saying, I've seen that name before. I know about these hospitals in the north or in the south, but I don't really know what they're doing. And the same is true for the coalitions. As coalitions become more of a normal thing in the Florida Stroke Registry, those coalitions are saying, I want to know more about what they're doing in the West. How are they accomplishing the things that they're doing? So that's why we put together this Coalition of Coalitions meeting. The in-person was very successful. We talked about the goals of the different coalitions, some of the barriers to their successes, and one of the barriers that they've encountered is just really membership engagement. It's hard, I'm certain, for you all to find the time to get together at all these meetings, but you know, getting together can be super important and valuable for the kind of things that you need locally. So we're trying to help with that organization of the meetings. Peter knows just the administrative aspect of getting you guys together, even though there's only a group of 17 here, could grow to 50. And even the 17, you all are super busy people. So FSR is trying to see if we can step in and help with some of that administrative aspect to get you all together. Again, with the website. Yep, absolutely. With the website to be able to give you information that's a local place where you can find it. And then opportunities to collaborate across the state, maybe with another coalition nearby you or with the entire 7 coalitions across the state. There's different things that we can do in collaboration as an entire group. So this is a new thing, and we hope that this inspires you, encourages you to be part of this new coalition, we're super excited and happy to service you in any way that you need. I think that's it. Yes.
Yeah.
I tried to go through that fast, Peter. I know we end up talking a lot when we have the opportunity, so I'm sorry if we rambled on too much.
That was perfect. And because you guys came in after your other meeting, would you mind just making introductions as well, both Carolina and Jillian, just to let everyone know who you are, because you're so important to this whole process. I didn't want to minimize that. So Carolina and Jillian, go ahead, make some intros.
Thank you, thank you. So I'm the one with the short black hair there. I don't have my camera on right now, but next to Dr. Romano, if you all know who he is, top row to the left. I'm Carolina Gutierrez. I've been part of the Florida Stroke Registry at all levels and happily and very proud to be a part of it now as the Associate Director next to Jose Romano. I work very closely with Dr. Sacco, and I think I understand the vision that started the Florida Stroke Registry, and I hope I can maintain the vision that the clinicians, the community, and others have. So that's who I am. And Dr. Gordon Peru?
Sure. I would say Dr. Gutierrez is a key driver of all things
Yes.
FSR. I'm sure everybody agrees with me when I say that. And I'm just thankful and grateful to work with her every day. I am Jillian Gordon Peru. I'm a stroke neurologist by training, and for the FSR, I'm the director of the education core. So we have multiple cores, as you saw on one of the earlier slides. And really what we're doing is transforming data into action. So if our data and our publication shows that there's an area that needs quality improvement, sometimes you guys don't have time to make the materials, the educational materials that is needed. We'll help make them with you, for you, working alongside you, so that you can then use it in your local region. So if you go to the Florida Stroke Registry website, there's a lot of videos there on stroke awareness, for example. And we're working on a few more things that I'll keep in my hat until a later date. But really, the aim is to transform data into action and to impact the entire stroke system of care. So we are thrilled and excited that you guys have started this in the Space Coast Coalition area.
Well, thank you both, Dr. Gutierrez and Gordon Peru, for joining us today. You guys have really led this registry in a direction that I only dreamed of many years ago, and I never thought we would get to where we are. Could you take 1 or 2 minutes to talk about the upcoming publication, which is so impressive? And I know that some of the data was discussed today, but can you tell us when that paper will be coming out and a little bit about it?
Yeah, we submitted it to Stroke, so fingers crossed it doesn't come right back to us. But who knows? Those things happen, and then we'll submit it again somewhere else. But in a nutshell, without having any data, maybe that could be the next at your next meeting. We can have the co-author, which is Victor Del Bruto. We can have him come on and show you some of the data. But basically, what we're showing is that we see a difference between hospitals in the Florida Stroke Registry. There's 180, right? And at this point, there's about 90, half and half, that are participating in a stroke coalition like you guys are now doing and looking at these regional dashboards. Looking at the regional dashboards on a quarterly basis and really tracking and measuring how well they're doing. What we found is that there were significant differences in their time to treatment and in the numbers of people, the proportion of people that they're treating, particularly in this case with IV thrombolysis. The next round of paper will probably be for the endovascular therapy, but this was very specific to IV thrombolysis. That's it in a nutshell. Peter, you're a co-author as well. Any more that I should say there?
No, I just think that it's so impressive when we're looking at all the numbers that are in that paper about how impactful the registry is, how impactful the coalitions are, and it's become much more clear, I think, to all of us who have been on this journey for such a long time that, and you both mentioned it very well, which is that stroke is local, and there's no purpose of us in Brevard looking at South Florida or looking at the northwestern part of Florida, right? Because that's not how it works. And so I would like everyone on the call to understand that this is all about us working together in unison with EMS. It's not a competition. And what I've loved, what I've loved is that in Broward, where there's a lot of competitive hospitals in Broward. Don't get me wrong. And what the coalition has done is that it brings all of the stroke coordinators, neurointerventionists, EMS medical directors together, and now they're sharing information. And many of the hospitals now are doing the same thing. Why? Because they learn from each other in this open, sharing, collaborative environment. While at the same time, they all maintain their little competitive edge, right?
Right.
But the outcomes became so much better, and that's just so incredible to see.
Incredible.
And so now maybe if you guys have a few more minutes, before you both joined, I put up this slide, and Caroline, thank you for putting it together. So basically, this is Brevard, Flagler, Indian River, Volusia. There's 4 counties here. We were going to have a discussion here because the people on the call today mainly are Brevard is basically here today, and I don't think we have Indian River's not here, and neither is Volusia or Flagler, I believe. And so the question is, how would you guide us if you were to guide the creation of the Space Coast Coalition? Would you advise us to have all 4 counties, and then, or would you advise us to kind of pare it down? Like, my thought would be to have more counties involved, because the volumes aren't going to be that high anyway. What are your thoughts, if any, on this?
I think, I think the first thing you have to think of is how crowded the dashboard will look with too many hospitals. That becomes a problem. Right now, I think you have in green, by the way, everybody, if it's not obvious, those are hospitals that are giving us data. They're in the FSR. The ones in yellow are still pending an amendment, and we don't have their data. And the ones in red, the 2, have not been giving us data. They're not part of the Get With the Guidelines, American Heart Association. We're in process of trying to get them on board, but we're not, we don't force them to be a part of that database. So the point you have to think about is how crowded the dashboard will be. And then more importantly, it really does matter about what EMS thinks about this, right? Is it valuable to have counties that are maybe far apart from each other? Does EMS transport to those counties that might be a little bit further up north or south in terms of Volusia and Flagler? Flagler may be already involved in the Northeast, even though I think that's a little bit further up north. But it really depends on you all. I think it's too many hospitals. I would recommend decreasing it a little bit. And we can always make 2 reports for this coalition. Just because you separate them in 2, you could always look at maybe just Volusia and clump everybody else together on one report. But it really depends on your tastes.
Maybe let me bring in Dr. McPherson, Chief Dominguez, and Dr. Ford, and then anyone else on the call. If we look at Flagler, which is obviously north of Volusia, or even Volusia itself, what are people's comments on those particular 2 counties? Chief, I see you unmuted.
Well, Volusia is a fairly populous county, with Daytona being the heart of the population. If they're not part of the coalition at this point, might be able to help them kickstart it in Volusia. I'm sure their medical directors would appreciate that, and probably the hospitals. Flagler is a relatively small county. It's kind of like Brevard. It's semi-rural, where they're, I don't believe they have a thrombectomy stroke center there in Flagler. So I'm sure they would benefit having clearer guidelines on transferring LVOs and tracking to see what hospitals do. But I don't know that.
Are they going north? John, do you think that they're going north from Flagler or to Halifax, or?
Well, they'd go south to Halifax. And
south to Halifax.
Yeah, and I think north of them, you've got St. Johns County. I'm not sure that there'd be any place in Flagler that would be closer to Halifax for an LVO.
So maybe it would make sense then, just looking at the total number of hospitals, 1, 2, 3. So because I think what Carolina is trying to say here is that there'll be 7 additional hospitals that are not really pertinent to Brevard, and maybe that would just cause an extra little bit of clutter. So, Dr. Gutierrez, I'll ask you then, because I know that they're interested. I've spoken to the medical director and to the EMS chief there. The question is, from the FSR's perspective, would you just create a separate dashboard for the Volusia folks, or would they have to create their entire own coalition to
No,
get
no,
involved?
no. Absolutely. If they want to be a part of this coalition, we can create 2 separate dashboards that are discussed at this coalition. If it's easier for
Okay.
them to be part of this one coalition, absolutely, they can be part of this. West Central Florida Stroke Council has 4 dashboards that we create for them. And basically what happens is the stroke coordinators get together, they review it, and anything that's outstanding in a great way or in a bad way, that's what's featured in their meeting. I think we do the same thing for the South Florida Stroke Coalitions, where we have 3 different dashboards,
That's
and we just
correct.
feature important aspects. So we can do that. We can have 2 different reports discussed at this coalition, if that works for you all.
Yeah. Yeah, I'm seeing a bunch of head nods. And then what I'll do is, and maybe with some help of some people on the call, I'll reach out to the people who are running those systems in Volusia and Flagler, just to make sure I have all the right people, and I'll get them on a call separately. I'll send them this video, of course, and they can watch it. And I want to make it so that they feel like they're getting value as well, which I think that they will. And I think keeping them in the coalition so they can join our meetings just makes a lot of sense. Um, just so you know, Sebastian is a primary, and I was told earlier that Melbourne is not a stroke center, Melbourne Regional. So just FYI on that. Right.
That is correct.
Any that's correct. Okay. Thank you, Chief. Um, why don't we open it up? I know we've presented a lot here. Why don't we open it up to the crowd? I'm very appreciative of everyone who joined today. I know that this is it's more data transparency, which is what we firmly believe in. It's working, and we now see that it's working. But obviously, from a hospital administration perspective, there may be some questions. Are there any questions that we can answer now that anybody has? Of course, we can answer them offline as well. That's number one. And then secondly, Dr. Gutierrez, next step with respect to getting our coalition up and running, our dashboard up and running, getting people passwords for the website. While people are thinking of their question, can you advise the group of what the next steps would be here?
Sure. For the hospitals, we'll have if the list of counties that we have there, the 4 are going to be part of this coalition, FSR will have those list of hospitals and stroke coordinators. We may or may not have the medical director, we may or may not have the CEO, but we'll send it to the stroke coordinator and of course to the leadership on this coalition. You guys let us know if we hit the right people to let them know you're going to get an account. I'm sorry, I'm going to be out of here in a second. Sorry, I snuck into a room and they're kicking me out.
Oh
So
boy.
I'm at the university. So we'll give it to the hospitals. We'll say we're creating an account for you all. Have at it, and we'll help. If there's any confusion about how to get into the secured section. It's a secured section in our website because it's not open to the public, and we can control who sees what. So that's why it works that way. For EMS, please send me whomever the director should be or whomever from the EMS system should have access to the website, and we can give them an account as well. That's the basic.
Perfect. Perfect. Okay, so I'll follow up on all these things to let everybody know, and then we'll get everyone on the same page, and then we'll go into the structure just so everyone on the call knows. My expectation next steps is that you actually will hopefully have people on the coalition that are more of the leadership of the coalition. That could be a stroke coordinator, that could be one of your neurointerventionalists, it could be, an administrator. Really, the goal is to have people who are leading the coalition so that every quarter we have an agenda, we have presentations. Maybe we can even meet in person. We've done that several times here in South Florida. And the goal is at the yearly that everyone kind of everyone joins and collaborates. They usually have it at a beautiful hotel. It's usually a 2-day conference, and we can really bring that together. So we have a couple of minutes left. Any questions? Any thoughts? Anybody have any burning questions or comments before we close out?
Well, great synopsis, Peter and Gillian, of what the stroke registry, the history of the development and the coalitions. And we appreciate your energy and initiative on getting this up and running in our region. Again, I believe that the semi-rural counties that have just one or maybe two stroke centers, the care of the LVO patient can be more difficult, and we need to track how we're doing. So thanks for both of you.
Thank you so much, Dr. Mack. I appreciate it. Anybody else? Anyone from any of your hospital systems? Alrighty. Our goal would be to do these now quarterly moving forward. Obviously, we have some tidying up to do. We have some information to disperse. If anyone's on the call who feels like someone else on their organization should have been involved, what we're going to do is I'm going to have my assistant send this out. I'll send this, of course, out to Chief Dominguez, and he can disperse it as well. But it's kind of like the more the merrier. And we really like these meetings to be well attended. Like Dr. Gutierrez said, 40, 50, 60 people would be a great outcome over time. And hopefully there's a lot of value here. So there's not really much work for anyone to do here because the work is being done by the FSR. It's really going to be, what will you do with the data when you see it? And how will it impact your moving forward at your local hospital? How will it impact working together with us on the EMS side, which we look forward to doing? So if there's no other questions, thank you all very much for joining. I'm going to stop the recording, and then we'll get this up and as a link that you all can send out to those people who missed it. All right.
Congratulations, everybody.